C. This is Kathleen Colleran, and we have several participants and a didactic and a few cases. And so before we get started, I would like everyone to introduce themselves. So one, we know that you're here. We will take roll call a couple of times throughout the session. And so I will start here, and then we'll go to other video sessions and then phone. So Kathleen Colleran, endocrinology, Comm Tc.
I'm Dan Rifkin. I'm a pediatric psychiatrist in the Department of Pediatrics working at Envision, New Mexico, and clinical programs.
This is Casey Brandt, pediatric nurse practitioner and QI coach at Envision.
This is Beth Goins, pediatric cardiologist.
And Kevin Worling, your IT support person for today. And just as a reminder, if you'd like to mute or unmute your line, it's *6.
And my name is Kirsten Bennett. I'm a pediatric dietitian here at Envision, New Mexico, and I'll be presenting the didactic today.
And just as a reminder also, we are recording today's session. Thank you for joining us.
Okay, and on video we have so far one participant. Oh, two participants. So if you could please announce yourself if you're at Echo.
This is Alejandro Rodriguez at the UNM Center for Telehealth.
Thank you. And I think, Jonathan, you're muted. Okay, let's go to the phones. Do we have anyone on the phone line?
This is Pamela Doster. I'm a social worker with Children's Medical Services in Socorro.
Other phone people? Okay, I anticipate we'll have other people coming on, and so as they come on, we will introduce them. So we're going to start with our didactic presentation that's going to be given by Kirsten Bennett, and you want to just proceed?
Okay. Okay, so today we're going to talk about the small for gestational age infant. And how that may give us some indications about future risk for metabolic syndrome. So what I want you guys to think about at this point is the idea that there is potentially a relationship between infants that are small at birth and the risk for development of metabolic syndrome. And I want us to begin to think about what are some of the proposed mechanisms for this relationship.
Just excuse me for interrupting. If you're not muted, can you please mute your mics or your phones? Thank you.
So as background, and you should know, those of you who've participated in Comm Tc with us for a while, know that this comes up when we look at where do we start being concerned when it comes to the risk of metabolic syndrome and the comorbid conditions that we see with adolescent and childhood obesity. So if we go back in history to the Dutch famine during World War II, 1944 and 45, a group of investigators went back and looked at increased levels of obesity and diabetes in those that were exposed to the famine. And they found that there was a relationship more so with those that were exposed during the first trimester than those that were exposed to the famine in the third trimester. In addition, there was an English cohort that was reported by Barker et al. In 1993 that looked at the risk of diabetes and metabolic syndrome in those with birth weights less than 2.95 kilograms And in that group, there was a risk of 10 times greater those who had a birth weight of 4.3 kilograms. In the Nurses' Health Study published in 1999, there was an 80% higher risk of type 2 diabetes if the birth weight fell between 2.3 and 2.5 kilograms. And one of the things, too, that came up in a more recent article is metabolic syndrome prevalence is more than double in the SGA group of infants studied by Reiner et al. In 2009, with an odds ratio of 4.08 than those who were not SGA. So there is some basis for why potentially we should be concerned. SGA is not an uncommon occurrence. The estimate is that 3 to 8% of births fall in this range. Potentially 10% of these may fail to show any kind of catch-up and becomes children and adults that are smaller, have short stature. The interesting thing that I found in reviewing for this talk and then working with this population as a clinician is that the classification of SGA varies depending on who you're talking to and what literature you're reading. But basically, if you look at -2 standard deviations from whatever chart you're using, usually you'll identify most of these infants that fall into this SGA category. Now, depending on how you get your standard deviation measure, it varies with the use of percentiles on growth charts. So if you're using less than the third or less than the 10th, and which type of growth chart you're using. Older terminology that we used to talk about in late 80s, early 90s was looking at symmetrical versus asymmetrical SGA, which I still found some reference to even in newer literature. An example being a symmetrical SGA is both the weight and the length are less than expected, versus an asymmetrical presentation where the weight is less than expected, but the length is what we would expect for that child's gestational age. And some of the supposition was that that's related to early versus late onset of change in the interuterine environment. So the earlier, the less optimal that the interuterine environment presented for the child, in other words, first, second trimester versus third trimester, that those children with earlier onset of a negative environment would be smaller symmetrically than those who were exposed later, potentially not gaining weight in that last third trimester the way we would expect. So the problem with this, however, is that if you read some of the obstetrics literature, there is percentile crossing during gestation, so the early versus late thing may not really be as useful as we used to think it was. And it certainly doesn't appear to be predictive of risk. So we need to talk a little bit about terminology. So IUGR, interuterine growth retardation, is potentially limited just to known processes causing growth restriction in utero. So there are several ways that obstetricians may look at this during the pregnancy. And depending on which cutoff that you use for SGA versus SGA cutoffs, IUGR does not necessarily mean SGA, so we'll talk about that a little bit later. Low birth weight, also at less than 2,500 grams or 2.5 kilos, does not also define SGA, because in this case it fails to account for gestational age. But keep in mind that preterm infants may be low birth weight but not SGA, so in other words less than that 2,500 grams but not small for where they are gestationally. So just to kind of clarify how we're going to group all these infants together today, SGA, small for gestational age, low birth weight, IUGR, and fetal growth restriction, or FGR, are all going to be sort of lumped together because even though we have varying definitions, it appears that all of these infants have some risk for metabolic syndrome. So the idea that reduced fetal growth, regardless of the cause, is associated with some risk. Now on the flip side, just so that we don't forget this population, LGA, or large for gestational infants, also have an association with gestational diabetes and long-term risk for type 2 diabetes and metabolic syndrome. And we've talked about that before in this group. So if we look at some potential mechanisms for why small for gestational age might be related to adverse metabolic conditions, we really are talking about the pathology of insulin resistance. So there are some ideas around that. One is that the fetus adapts to the interuterine environment, and that's true in almost all cases. But the idea is that that prepares the infant for an environment, hopefully that's similar to the one that the infant was exposed to in utero. The problem is that if they're born into an environment that's different than the one that they're prepared for, then that doesn't work so well. And potentially we get into this discussion of this thrifty phenotype or genotype if the infant has adapted in that way. And that indicates that the fetus has potentially adapted to a glucose-sparing metabolism where there's inadequate glucose in utero. So the fetus, the malnourished fetus in this sense, directs nutrients to organ development. So we end up with some peripheral insulin resistance and reduced lean body mass, and we're going to talk about that some more. There also may be a genetic predisposition for infants, small for gestational age infants. And the other thing to keep in mind is adiposity rebound during catch-up, and that's what we're going to look at in terms of potential solutions that we have for mitigating some of this risk. So in terms of body composition, at birth, SGA infants have less adipose tissue than AGA infants, okay, because they're smaller. But the interesting thing is catch-up growth increases adipose tissue relative to lean body mass, so it increases it more. So when they catch up more in terms of fat tissue than they do in lean body mass. So you have this increased fat mass to lean body mass. And it's not specific to small for gestational age infants. You'll see the same thing in adult populations. And it's not simply a result of overeating or exceeding daily energy requirements, because again, we're talking about this sort of thrifty or efficient or efficiency versus overeating kind of path. The other thing is that the body, when it sees a depletion of fat stores, that signals a suppression of thermogenesis and accelerates fat accumulation because we want to get back to where we started before there wasn't enough food for us. So during recovery growth, glucose is directed toward rapid reestablishment of adequate fat stores. So it's not directed toward growth or lean body mass development. And unfortunately, along with this reestablishment of adequate fat stores, and maybe a little bit on the far side of that, we end up with this, again, increased insulin and insulin resistance. So I'll walk you through a diagram here. The idea is that there's a difference in the way we catch up in terms of our fat stores. So we've already established that when we catch up, we're going to add fat first. So the difference is whether it's hyperplastic or hypertrophic. And hyperplastic means we make more fat cells, and hypertrophic means we make bigger fat cells. And so the fat cells that are really big and really full versus lots of fat cells who can handle a lot more fat. And so one of the things that we're going to talk about in a future Comm Tc session is what this kind of pathway looks like when it comes to ways in which we can change dietary interventions that might impact how these fat cells function. But the interesting thing is that when the adipose tissue can no longer sequester fat, in other words, these big cells can't take up anymore, then they send out signals to tell all those cells around them they're not doing so well, that they can't take up anymore. And so what we end up with is hyperinsulinemia as we try to figure out how we can get cells to take up more fat versus a situation where you have plenty of fat cells, even though you're still overweight and you still have more fat than you need. The fact that we have more cells, they're actually able to do their job better. And so we don't end up with this hyperinsulinemic state because you actually have maybe mild systemic insulin resistance or localized ectopic insulin resistance, but you end up with normal glucose tolerance if we were to test. In the other situation, we end up with systemic insulin resistance that's pronounced, and we end up with what we can diagnose as impaired glucose tolerance. So we'll come back to this big topic on another day. So we need to really consider what happens in postnatal growth. So when we talk about kids who are smaller than what we expect when they're born, we really talk about catch-up growth. And we talk about catch-up at many times during pediatrics where there's been some kind of insult where the child has not grown to our expectations and they get over their hospitalization or they've had a surgery or they had a significant illness, and then we expect that there's going to be some recovery, and that's catch-up. But to define it in terms of the SGA group, follows some kind of growth retardation, either a perinatal insult, IUGR. It involves crossing of centile lines, so regression to the mean. So we get back to what sort of the average optimal expectation is for that child or for the population. And it involves bone, muscle, and fat, so it's not just fat, though we did talk about already that the fat mass accumulates faster than lean body mass. And the interesting thing is that if you look at a lot of these references, Ketchup might be a hallmark of IUGR. So even though you might not have defined a particular child as IUGR or SGA, the fact that they exhibit this kind of catch-up growth may lend you to that conclusion that they actually are below or behind what you would expect at birth. Now the difference is accelerated growth, and so if we define that, that can occur anytime. So those of us who are adults, we can accelerate our growth. It's not going to make us taller, but it usually is a result of excess energy intake, and we end up with surplus adipose tissue. So we get none or limited acceleration of linear growth. So this can happen certainly in an older child. Even if their linear growth is what we expect, they can have accelerated growth, which just results in them developing more adipose tissue. And then if you think back to our little diagram, depending on which way their body goes in terms of how it handles that excess fat accumulation, can determine their risk for metabolic syndrome and what we need to do about it. The interesting thing, again, is many of these studies lacked a distinction between the two types, whether we're talking about catch-up or accelerated. So for our definition, we're going to use catch-up in the sense that we have the possibility to impact linear growth and lean body mass also. Those of you who have worked with young children know that you also have to be a little careful here, because it's difficult to assess catch-up and whether or not it's excessive, because for catch-up to occur to impact linear growth, you do have to have weight gain and then linear growth. So in other words, kids will put on a little bit of excess adipose tissue. It's kind of like that situation where, why in the world would your body invest in new skeleton and new muscle, which takes more energy to maintain, if there wasn't an adequate food supply around or an adequate reserve? So you will see these kids kind of get chunky and then get lean, and chunky and get lean as they invest in linear growth. So that's a normal pattern which you can follow if you're following these kids closely and making sure that you're plotting their growth on some kind of growth chart. The other interesting thing may be the timing of postnatal growth. So is it rapid? Early catch-up appears to be more detrimental, and so if we define what is early, for rats and mice, if you look at those studies, it's usually the first 1 to 2 weeks. In humans, it's the first 3 to 6 months. And if you think about the population of kids that we work with, that's the time when we're most concerned about them for many other reasons. That might be the time when they're most intensely involved with the healthcare system. They're in an ICU setting, a hospital setting, they're getting home visiting, they see their pediatrician more often. So we're really paying a lot of attention to their growth, and the tendency there is to get them to grow fast during that period of time. The interesting thing, this last article here, Jimenez and Chiron article from 2006, was really looking at the rats and mice, but the experiment was looking at prenatal metabolic adaptations might be modified by postnatal intervention. So that kind of gives us sort of the jumping point where we can discuss what we do with these kiddos after they're born and how we manage their postnatal weight gain. So again, critical periods of excess weight gain that are associated with later obesity risk up to age 6 months, and then after age 2. So what's acceptable for postnatal growth? One thing is that we've had the discussion here before, and those of you who attend P&T also hear me talk about the different growth charts that are out there. One is the CDC chart, which is the standard one we see in a pediatric clinic. It is a reference chart. It's not meant to be a standard. It's meant to have a place to put down the child's growth parameters so that you can follow them over time, but it's not prescriptive. In other words, if they're at the 25th, the goal isn't to get them to the 50th, and if they're at the 50th, the goal is not to get them to the 90th. It's just a place to kind of track how they sort of fit in the reference population in which they're being compared to. The World Health Organization charts, however, are standard charts. So in other words, they are meant to be prescriptive, and they're based on a breastfed standard. And again, folks can argue, if you go back and read the source documents, about whether or not you believe that's true. So the question is, should we use this standard when we're developing assessment standards for postnatal growth? Because what we do know about breastfed infants in that first 3 to 6 months is they tend to have slower, more prolonged weight gain early on than compared to their formula-fed counterparts. The other thing is to consider, in terms of charts, should we be using postnatal or intrauterine growth charts? So I've given you an example of a couple, and then in your handouts there were 3 other handouts that address this topic. But the Olson charts that came out in 2010 are intrauterine growth charts, and the Fenton charts from 2003 combined fetal with term infants. So you would plot a child who is in a newborn intensive care unit or in the hospital setting who's born SGA and potentially preterm. On one of these charts, comparing, again, fetal growth, and then at the point where it intersects the data from the term CDC charts, then you would plot them there. None of it's perfect because we know the intrauterine environment is obviously different than what we have postnatally, and those kids who we have that kind of information on might not be the best examples for us to be comparing to, but it's what we've got. So, you know, my suggestion is to use all of them. Whatever you've got, plot it, because it gives you a little bit more of a picture of what's going on. The other thing to do is to keep in mind what the expectations are for catch-up. Again, you know, 10 to 30% of these kids might not catch up. And the ones that do usually catch up within the first 3 years. So those kids are going to be less than the 10th percentile on the CDC charts. Now, if 30% are less than the 10th percentile, that doesn't mean that that's really a problem. Somebody has to be less than the 10th percentile. Because again, these again are not prescriptive charts. The CDC charts are reference charts. So when we look at the assessment of postnatal growth, the first thing we have to consider in preterm or small for gestational age population is there is an initial diuresis. And in term infants, you know, it's somewhere up to 10%. Beyond 10%, we get a little bit alarmed that they've diuresed that much. In preterm infants, you might get a greater diuresis. Again, usually that's controlled to some extent by the amount of fluid resuscitation after the infant's born. But potentially you're looking at 7 to 10% water loss initially. And usually in an infant who's able to eat the way we would expect, we're able to meet their caloric needs as we would expect, they would regain their birth weight by 10 to 14 days. Now, the interesting thing is, having spent the first part of my career in pediatrics in the newborn intensive care unit, we were really, really, really committed to making these babies gain weight really fast. And I still see this number out there, but 15 grams per kilogram per day of birth weight. And I'm thinking, after looking at all this, that this might be a little bit overzealous. So if you take just the 2.5 kilogram infant, which is the cut point for our definition of low birth weight, remember we're going to consider those guys high risk too, that's a goal of 37.5 grams per day if we base it on their birth weight. Well, we don't even expect a term baby to do that. We expect them to gain anywhere between 20 and 30 grams per day and not have that based on any kind of birth weight. So yeah, we want catch-up, but how much catch-up do we want? And are we concerned about the way that infant stores that excess energy? Yeah, we know that there's going to be a diversion to adipose tissue, but do we want to maybe control how that adipose tissue is created? In healthy SGA infants, in terms of managing that and looking at that, we weigh those babies weekly. And again, these are not the ones that are in the ICU who get weighed 1 or 2 times a day. We average a gain for over 2 weeks, and actually I did that even in the ICU. Even though we looked at them every day, we were potentially looking at fluid changes, but I would average their weight gain over 2 weeks to really assess whether or not they were going in the direction I wanted them to go. So what I'm suggesting, and this is just based on me, myself, and I, is considering a 0.5% per day weight change, which is more consistent with the expectations for term infants. So if you look at a 2.5 kilogram infant with that goal of that 5% change, that gives you the goal of about 12.5 grams per day. So in other words, they're gaining weight. We realize that there are some issues with the way we provide nutrients, but this might be especially important in that first 3 to 6 months of life. If we're looking at that rapid postnatal weight gain and rapid catch-up might predispose them for growth. So then we can look at the alternatives at the end here. So the other thing is to talk sort of globally, especially those of you who are in primary care practices. What can we do to prevent SGA? Because that's the best way to avoid this problem in the beginning. One is maternal factors. So if we have an option to talk to moms and potential moms about limiting caffeine consumption, if we promote prenatal nutrition, because well-nourished mothers have better outcomes, stop or limit maternal smoking. So even if mom can't completely stop, if we can get her to smoke less, that's helpful. Promoting a healthy maternal BMI, so preconceptually and during the pregnancy, making sure that we have adequate weight gain but not excessive weight gain. And then minimizing prenatal environmental hazards. And this is primarily for those folks who work in some kind of industry where you have noxious chemicals around. So what are our options really for managing postnatal growth? Because the thread that I'm trying to tie here is that even though a child's born SGA, we may be able to limit the risk they have for metabolic syndrome by managing their growth differently, especially in that first 3 to 6 months. So we need to rethink the weight gain goals in high-risk neonates. Use all the charts together to get a better picture of where this child sort of fits in the spectrum. Promote breastfeeding in any capacity. So even those kids who are in the ICU, if we can give them a little bit of breast milk. And watching, calorie concentration of discharge formulas. Because what happens a lot of times is infants do really well, and I'm of the same mind. If they're doing really well in the ICU and we send them home, I do want to send them home on the formula that they've done really well on. The time to change the formula is not 5 hours before they go home with mom and dad. However, we do need them to pay attention to what happens to their growth once they go home. So we really have to watch. If we send them home on a 24 calorie or 22 calorie formula, we may need to change that. We may need to change it fairly quickly as their growth changes. We need, as the group of providers who are concerned about this, to support primary health care providers who care for high-risk neonates. Because again, it's only 3 to 8% of their population, so they're more likely going to be coming across infants who don't have these kinds of risks. So supporting them in monitoring postnatal weight gain. Interestingly, the BMI screening may not identify these children as they grow. So even if you use the World Health Organization charts, which allow you to calculate BMI from birth, BMI is not sensitive to body composition. So in other words, we can calculate a BMI on a box of rocks, but it doesn't tell us that it's a box of rocks. Okay, so it doesn't tell us anything about lean body mass and adipose tissue. The other thing is to be real upfront with parents, and we've talked about this. How do you do this in a sensitive way without scaring people? Counsel parents on potential metabolic risk. And, usually parents get the message that there's a neurodevelopmental risk. That seems to be the conversation that people have around discharge of high-risk neonates, especially small ones. But the idea that puts that child in a different category, not only for neurodevelopment, but also for potential metabolic risk. Maintaining healthy BMI, so making sure that key lifestyle messages are occurring early in that child and family's life. Screening early. There was a 2010 article from Hungary that suggested in this population really monitoring growth a lot more frequently. So even though in the first few months the child, or the first, I'm trying to think, help me here Paula and Casey, there's sort of this push in the first few weeks and the first couple of months to get all these immunizations in, and after that you see this huge fall off in terms of when infants come back to clinic. And so the suggestion here is don't drop off. In other words, don't go to that once a year well child visit in these kids. Have them come back every 6 months with the express idea that you're going to monitor their growth and change things if you need to. And my guess is after 6 months, if kids are doing well, you don't see them for a while. It might be 12 months or 18 months before you get them back, and by that time, the family started food, and and they may not have had their formula changed because it was okay at 5 or 6 months, but now it's 12 months and this kid's still on 24 calorie formula and they're gaining weight at 40 grams a day. We probably don't need to do that. The other thing is just to consider balance, and this is always the discussion when you sit around a table with families and providers talking about a high-risk infant. You need to balance the need for catch-up growth and optimal growth, because we certainly don't want to reduce this child's potential to be 6'4" if he's going to play as a center on the basketball team. However, we also don't want to increase the risk for other things that may happen down the road. So we really need to look at sort of that overall health and development across the lifespan. And if you're seeing these kids more often, every 6 months, then it certainly gives you a better opportunity to have that discussion. So many pages of references, lots and lots of wonderful reading. There were 3 articles that I stuck in your handout packet on potentially 3 different growth charts, and also there was one article that talked about, well actually they're all growth chart articles, so that you can see what the options are for preterm infants. So those of you who haven't announced yourselves, now would be a good time.
And please remember to... Sorry, repeat that?
We're having a little hard time hearing you. Can you please restate your names if you've just done so?
Dr. Steve Rankin in Farmington.
Great, Steve. Thanks for coming on today.
Oh, thank you. Appreciate it.
Mine's Chapin here from Albuquerque.
Thank you.
So, any questions?
Nancy Whalen, pediatric cardiology.
Hi, Nancy.
Hi there.
I'm sure, Nancy, you wanted to hear about SG infants today, right?
Oh, it's interesting.
You see a few of them in clinic.
Yeah.
All right, any questions or comments about the didactic today? Otherwise, we'll let Dr. Chilton go on with his patient presentation.
Just real quickly, a question from this end of the table. I'm the pediatric psychiatrist, Dan Rifkin, and I don't get to use the growth charts as much outside of the clinic one day a week. Would you please review and elaborate on the difference between the CDC's reference chart and the WHO standard chart? You mentioned that the standard chart is prescriptive.
It is prescriptive. So the difference between the reference chart is that basically a sample was selected that was supposed to be representative of the population of the United States. And that if your child shows up anywhere on that chart, that things are probably fine. Okay, it's just a place for you to compare your child. So it's like going to your child's classroom and say, okay, let's line up tallest to smallest. You know, that's basically it. So in that classroom, so if you can imagine taking many of those samples, you actually get a set of curves. And all of those would be considered, you know, typical growth.
So it could be considered to be normed on a group of American children.
Right. And
Okay.
some are breastfed, some are formula fed. So there's a
Okay.
mix. In that group, the CDC charts that we're using now, none of the sample for kids over the age of 6 were included in this last sample because of the increase in obesity. So we actually, the data set for some of the older kids came from the earlier 1970s, 1980s data set because it would have skewed the curve to be okay to have a BMI of 29 when you're 12. So after age 6, then you're looking at old data, just so we don't have that skewed picture of obesity, because it would make those kids look typical, which they are when you walk around the street, but that's not what we want. That's not a good clinical picture. The WHO charts, because the sample was very carefully selected to describe the way growth should be, based on what we know should happen with infants. They should be breastfed. So there were no formula-fed infants at all, and they were from 8 different countries. And they followed them over the course of 5 years, so from birth to 5 years. So BMI charts were constructed. They also, in that same sample, then developed developmental curves, and there are developmental guidelines that go along with that same sample, so that you could potentially use those as a screening tool also for not only growth but developmental concerns.
Thank you.
So this Beth Goins from cardiology. So because we're talking about kids who have health problems, you know, in cardiology, I also am of the era where we try to feed them to get them big for their cardiac surgery. So how do we decide, because we're thinking of wound healing, ability to be tough enough to take any of their medical issues, how do we decide when we've achieved that, like adequate nutrition for that sort of thing versus just weight gain?
So I think one of the things you're looking at is actually that child's growth curve. So if you had a child that you think is less than a 5th percentile and you don't think they should be there, then, you know, what are your strategies to get there? But if what you show is adequate progress towards regression toward whatever mean they're supposed to be on over some time, then you could assume you're on the right trajectory. So for that moment in time, they have the nutrient stores they're supposed to have. Now, that doesn't answer the question, is it okay to make them a little fat, because we know that in 3 months after cardiac surgery, they're not going to eat well, they're not going to, you know, so that they have some reserve. You know, that doesn't really answer that question.
What about a lab test or something like, you know, I'm not very familiar with like pre-albumin or whatever.
Right.
Is there some way saying, yes, I'm in the appropriate nitrogen balance?
Yeah, absolutely. We do that. So you could do nitrogen balance, you could look at pre-albumin levels. There's lots of different things. That retinol binding protein, I mean, there's all kinds of things that you can look at to assess nutritional status. You can look at vitamin levels and iron status and, you know, everything else. If that is really what needs to happen, and then you would spend enough time nutritionally rehabilitating that child until they get to that point which you think they're going to be able to withstand the surgery.
But could you also say, this looks fine, and so I'm not going to push to get them fat?
And I think we have that question a lot in kids with developmental disabilities, because we tend to look at them as needing to be on one of those growth curves. And you know, when I worked with that population, looking at something called subjective global assessment, which is actually a physical exam performed by a nutrition provider that looks at lean body mass and fat stores. And so if anybody's interested, there have been some. We used to use it in adults with cancer, renal disease, but last year there were the same process was adapted to pediatrics, so there are now tools that you can use. But I used to use it when we didn't have the pediatric tools, and in my discussions with children who were, had varying levels of ambulation. You know, I don't need to see fat rolls. As long as your child, I can't get my hands between their ribs when they hold up their shirt, this is not a child that I want to gain any faster. I know lean body mass is an issue, and we can't use their overall weight as a marker of how they're doing nutritionally.
Yeah, because our population is the population where 1/4 of them have some sort of syndrome. And if it's rare enough, you don't have the growth chart for that syndrome. And this idea to generically try to get them heavy is...
Right, and we're all trained that way initially. Bigger is better. And what we're finding out in this population, I was one of the culprits when I spent that time in newborn eye. Man, we wanted them to grow. We did everything in our power. But they're, you know, slowly it's hard to get people to change their habits, but I think that that's, you know, sort of heading that way, that we're being a little bit more reasonable in the ICU. Now that doesn't solve the problem of when the child goes back to their primary provider, and that's where I think kids get really lost, because they go home on something. One of the kids that was presented today in pediatric nutrition telehealth, the earlier clinic today, was a kid that was like that, was failure to thrive initially, and by the time we had the child presented here, you have a child that now has a BMI in the 97th percentile. You know, and so that transition of when do you stop being concerned about failure to thrive when their developmental skills and feeding skills catch up to their metabolic risk.
Other questions from the audience? I do have, this is Kathleen, one question. So, are there lessons learned from preterm babies who aren't really small for gestational age, but they're small? And how does that relate to term babies born small for gestational age?
So when we went back to that one slide where we grouped them all together, really the risk is there even if you're low birth weight.
Okay.
So a preterm infant could be preterm AGA or appropriate for gestational age, but still less than 2.5 kilograms.
Yeah.
So there appears to be that risk even for low birth weight,
Okay.
irrespective of small for gestational age. So in some sense, I suppose we could lump them all together.
Okay.
And the issue's the same. We still want those kids to grow, and so we get very involved in wanting you to be like we thought you would be when you were born at 37 to 39 weeks.
I was just wondering if physiologically they handle it differently, or metabolically if they handle it differently.
I didn't see that sort of divided out or parsed out. My guess is probably.
Yeah.
Because you have a more mature system.
Yeah.
Even for a kid who's low birth weight, small for gestational age, but term, those kids got there for a different reason than the kids who just had the bad luck of being born at 28 weeks for whatever reason.
Okay, thank you.
So for children who are SGA or even LBW, is there a protocol, if you will, for a very gradual increase in caloric and nutrient load that will permit them to gradually take on more without being at risk for metabolic syndrome?
So you got my
obesity?
version, right? You got my version of how we should do that. And realizing that that is my version. I haven't seen anything in the literature that's that prescriptive, but I was throwing that out as a potential, idea that we abandon being so overzealous when it comes to these young infants. And certainly from the standpoint of nutrient quality, you want to make sure they get enough adequate protein, that they're getting all the micronutrients, vitamins and minerals, and we can certainly do that without making them fat. In other words, we don't have to give them all the extra calories and still see this kind of growth. I think we do have to help people understand how to manage these kids over time and really evaluate their postnatal growth. And I think that's where our work with our primary care providers really comes in. We need to figure out ways for them to manage, and also not be afraid when the kid's not gaining 40 grams a day, that it's really okay for this child to gain 20 grams a day, especially if you're looking at all the other things you're concerned about, you know, the child's neurodevelopmental progress.
Thanks for clarifying that, Kirsten.
So you have Kirsten Bennett's version of how to manage postnatal growth.
And where is that being published?
Right here on Comm Tc.
Well, thank you. That was a fabulous presentation. Are we ready to move on to cases? And if so, Dr. Chilton?
Yes. All right. Thank you for letting me present to you. And I apologize that I am in a car with a cell phone and not talking while I'm driving, by the way. And so I don't have in front of me the numbers that you'd like to have, but I believe somebody there will have those.
We have them up on the screen.
Okay. Oh, good. Okay. So, I can't see the screen, of course, but...
That's good.
Yes, that's right. So I'm presenting a 12 or 13-year-old boy who has been my patient for most of his life, and who we thought had an autism spectrum disorder for many years, and maybe has some characteristics of that. And a few years ago, when he started to have vision problems, he was referred first to an ophthalmologist here in Albuquerque, and then later to an ophthalmologist in Portland, Oregon, because of some unusual findings. The upshot of that was that he was diagnosed as having Bardet-Biedl syndrome, which is a syndrome which includes gradual onset of blindness and mild mental retardation and an eating disorder, which is really not unlike that of Prader-Willi syndrome. It was interesting to hear you speaking, Kristen, of patients who are underweight to start with and overweight afterwards. And Prader-Willi, I guess, is the best example of that, where they often are very hard to get to gain weight, and then much too easy to gain weight after that. Anyway, so this patient with his behavioral symptoms was at an earlier age begun on risperidone and on several other medications which I can't remember. And about the time that his vision problems were noted and diagnosed, he also began to gain weight rapidly. And it turns out that indeed Bardet-Biedl syndrome is associated with rapid weight gain and insatiable appetite, and not unlike that of Prader-Willi syndrome. So my questions for you are there any specific treatments for the insatiability that are different than they are for Prader-Willi syndrome, number one? And number two, if risperidone is the drug that is associated with rapid weight gain, are there other antipsychotic agents that are less likely to do that?
Okay, thank you, Dr. Chilton. This is Kathleen. I'm going to summarize the case and then add in the items that you did not have in front of you. So you have presented a 12-year-old Hispanic male who has been diagnosed with Bardet-Biedl syndrome with its associated blindness, obesity, mental retardation, and possibly some autistic features. His height percentile is the 23rd percentile. His weight percentile is the 92nd. And that gives him a BMI percentile of the 98th. We don't have blood pressure readings. On family history, there's a probable history of type 2 diabetes in his grandmother. You did report his birth weight was 5 pounds 11 ounces, which is, I assume, is not small for gestational age. He was bottle fed. And then the medication that he's currently taking includes risperidone, methylphenidate, melatonin, and ibuprofen. Regarding his social history and behavior, his sleep assessment, you reported at 3 to 9 hours, which is somewhat interesting in and of its own. And he shares a room with his grandfather. And then finally, you report his nutritional activities: 1 soda a day, but many juices, 2% milk, basically no proteins no fruits or vegetables. He doesn't obviously watch television because he can't, but he apparently listens to it. And then on his physical exam, really the significant thing is that he's got truncal obesity. And he has readiness to change as a 7 out of 10. He's confident that he can make those changes at a level of 7. His mother, who's his main caretaker, reports a 10 as her readiness to change, and an 8 to 9 as her confidence level. And she perceives this as a problem for the child. And so again, your main questions are: how do we help avoid obesity and feeding and eating behavior in this child? What's the physiologic basis of obesity? How do we work with him on a more balanced diet? And what about physical activity? And we're also going to comment on the medications that he's taking. So I'm going to go ahead and start with a couple of the first 2 questions. So this is one of those rare syndromes. And you're right, it's very similar to Prader-Willi with distinct differences. And in this case, it's hypertonia versus hypotonia. The etiology of the feeding behavior is not known, and it's likely multifactorial, but because this condition involves vision loss, it can also be associated with decreased smell. It suggests that it's probably a complex neurotransmitter related or nerve development disorder. And so likely the obesity comes from the hypothalamus, where the satiety receptors are and the hunger receptors are. It hasn't been clarified, but that's likely the cause. And so when those don't work, then what happens is we get hyperphagia, immense food craving, and that urge or sensation is so powerful that it will lead to any and all forms of finding food. And so when we talk about the behavioral issues or how to curb that, we're really talking about the same thing as Prader-Willi. There's not really a difference. So one is restriction of access to food, and then 2, behavioral either distraction or something to try to limit the great sensation of hunger, so that they're not always really trying to go that direction. It's very difficult. I'm going to propose that we actually do this as a specific didactic, because it's not only an issue in kids with these syndromes, but also in kids who are using food as a weapon or as a comfort, or parents are using it as a way to calm the child down. So I think it's really worthy of probably a more general didactic. But so the items are the same. And then your third question was, how do we convince him to eat a more varied diet? Well, one way is to just make that the only thing available. And again, because of the sensation of hunger, they will go to whatever food they can get. And so if the only foods they can get are healthy and nutritious foods, then that's the way to go. He's in school, so that's slightly a different ball game, but in general, that would be the avenue to take. And then your third question was about exercise for a nearly blind child, and I'm sure that you've probably commissioned or he's probably in contact with the services for the blind, And there are lots of opportunities for school-age kids to get services. So if they want to do track and field, so they will find somebody to actually be the assistant. There's also many programs, adaptive programs outside of the school system. But again, it's the Commission for the Blind who can really help direct that. And I will ask my colleagues to further elaborate. And then I do want to eventually ask Dan about these medications. So other comments from either the external audience or our group here?
There's also Special Olympics. This is Pamela out in Sapporo. Just wanted to mention Special Olympics for additional exercise.
Good. Do they have programs particularly for blind children?
Different think adaptation children with different disabilities. Whether they have hearing loss, vision loss, they make adaptations for it. Swimming, whatever, they make adaptations for it.
Thank you. Dan, can you comment on the medications?
Yes, I sure can. Primarily, of course, commenting on risperidone, known as Risperdal, methylphenidate, and I'd also like to comment about melatonin, although it may or may not be relevant to your question at this point. I think Dr. Chilton is very aware that risperidone or Risperdal can cause weight gain in a big way, and is known to put youth and all individuals who take it at risk for metabolic syndrome, and therefore it's very important that any individual taking this medicine be involved with important lifestyle changes like we talk about here at Comm Tc. Dr. Chilton also has talked about the challenges in incorporating these lifestyle changes for an individual with the syndrome that's been described. Specifically, Dr. Chilton, you were asking about an alternative medication for risperidone, and Abilify, which is aripiprazole, the generic name aripiprazole, has been found to cause less weight gain than the other atypical antipsychotics. And if you'd like to explore that option further, I know you have psychiatric consultant available at Young Children's Health Center. Also, if you would want to discuss it for further consultation with me, I'm available here at Envision New Mexico and have some time specifically available for that. Ordinarily, the dosage would be starting at 5 milligrams, but I think the best place to start is to look at what the current dosage of Risperdal is. We always want to start low and go slow with these medications in the pediatric population, and especially for an individual with a profound developmental disability, we want to be even more careful. I get the impression from hearing Dr. Colleran and you speak about this individual that there may be unique aspects of this individual's central nervous system to be considered.
Yes, I suspect so. And being as he is developmentally delayed, his ability to understand the need for changes is decreased. So he's not severely retarded by any means.
Would that mean that this individual may understand that weight gain may be reduced by changing the antipsychotic medication, of course without use of that terminology?
Well, I don't think he cares what medication he's taking. I do I did try to stop the risperidol at one point, hoping that he could do without it, and that was clearly not the case. But both he and his mother are amenable to changes, as long as we watch carefully to make sure his behavior doesn't deteriorate.
Lance, I gather then that his behavior did deteriorate when the risperidol was reduced in dosage?
Correct.
And was it a aggressive behavior?
I beg your pardon?
Did this youth become aggressive?
I believe so. I'm not sure that I remembered it. Sorry.
There could be consideration of a different medication class, especially if the behaviors are impulsive, which is often the case for developmentally delayed individuals. It may be worth trying an alpha-2 agonist. I would recommend guanfacine over clonidine. And that could be an alternative to the atypicals altogether.
That's good. Okay.
And I would be glad to consult with you about the initiation of an alpha-2 agonist.
I think, Dan, that somebody like you or Cynthia King are probably the ones to do the manipulation of medications. I don't feel very comfortable doing that myself.
Well, if you decide you want to give it a try, I sure would be glad to do provider-to-provider consultation with you. It's a real handy attempt to make, and certainly can be done on an outpatient basis because you have the risperidol to fall back on if the other medication trial is not efficacious.
Okay.
Okay.
And does he know how to cook? I'm sorry, go ahead, Dr. Shilton.
Well, I'm sorry that I didn't in my presentation mention one of the main concerns that you did bring up in summarizing what I've written, and that is that this child's diet is very limited not in quantity, but in the number of different foods he is willing to eat. I can't remember what it was exactly that he eats, but it's very few things. And it may be that talking about that problem, which is not confined to just kids with syndromes, might be another issue to talk about at one of your sessions. But in his case, it's very important.
Mm-hmm.
I like the idea that he's going to eat anything, including even fruits and vegetables, if that's the only choice he's offered. And I can give the mother that information. But with a lot of patients, that isn't always the case. They try their parents' concerns without eating anything until their parents get in and give them their cheeseburgers or whatever it is they want.
Yeah, but usually these kids don't do that. And again, it's because of the underlying disorder.
So that's really a benefit of this disorder in his case.
Sure.
The issue then is primarily to work with the parent.
Right.
Yeah.
Because I think that's where the intervention has to come, is working with the family to change their eating habits. I'm assuming that they probably eat
Right.
the same as this child, and that's going to be the major challenge here, I think, is to work with the family to accept, buying fruits and vegetables and maybe learning how to cook a little bit differently. And
Although if he has this much hunger and this much behavioral issue that he has to be on these medications, I think thinking about how much strife happens in a family is often what I hear from parents. We think just have the food there, but if you're unable to do your day-to-day life because the child's very upset about not getting what he wants. And what your question about whether it's aggressive behavior or whatever, sometimes I think that's really what makes it not as easy as it sounds.
Mm-hmm. And it's by no means easy. But so you can have free food. So free food are carrots, celery sticks, and rice cakes. Very low caloric. You do get the sensation of eating and of satiety. But it's by no means easy, and it really does require a multidisciplinary behavioral intervention, and everybody's got to be on board.
Yeah, the other thing that's part of that, similar to Prader-Willi, Dr. Chilton, which you probably know, is that even with Prader-Willi, you can't allow unlimited foods, because the issue in Prader-Willi is that people will eat until they have the gastric rupture. So you can't just have, you can have better choices, so they're allowed a larger quantity, but there is at some point going to be a limit to the amount of food that can be consumed in a particular period of time. Though I'm looking at the nutrition and physical activity habit portion of your presentation, it looks like the mother's concerned about the child's nutrition and diet quality, and so that's a really great place to start with them. The other thing is that I'm always suspicious of reports that kids don't eat very much, don't like certain things and have limited intake when I see fast food 5 times per week. So what that means is it only chicken nuggets and that's the only thing the child will get, or is the child actually willing to eat a meal of some kind at some restaurant? And that means then we probably have a lot more to work with if they're actually able to do that. So, you know, those are some things potentially to consider, and the potential motivation of the grandparents, where you've commented that type 2 diabetes is probably something that both grandparents are dealing with at the moment.
And just as this is Kathleen again, final comment related to that is, you know, simple things that can be done is that the 2% milk can be reduced to fat-free milk. That's going to decrease the caloric consumption, and it sounds like there's a lot of juice, quotation marks, which may or may not be juice, but water. What do you say about water?
It's always good.
It's always good.
Quench your thirst with water.
Quench your thirst with water. And however, if this, again, a child and you're working on all these behavior things, if they need a little bit of sweet, you know, half a packet of Crystal Light, you know, the little ones that you put in the water bottle, instead of putting the whole amount in there, put half of that. It gives a little bit of taste. Adults like flavored water, even if it doesn't have calories in it, and kids seem to take fluid better that way. So that's not a bad strategy. And if it deals with the I want juice thing, that's a potential.
Yeah, right. So those are two simple things that are likely not going to lead to big behavioral objections.
Right.
Good.
Also, Dr. Chilton, Dr. Colleran was just about to ask if you know how to reach me at Envision, and certainly for provider-to-provider consultation, Clancy can arrange that for us, and she can be reached at 925-7602.
He can't write because he's driving.
Right, but I know that Dr. Chilton will just remember that. But I'll also acknowledge the potential complexity of the psychopharmacology here, because I'm noticing that this child is also receiving methylphenidate, and I think that the assessment of workable medication for this child also needs to consider how important the methylphenidate is. From the basis of the pharmacologic theory, it's always important to question whether a dopamine agonist is good to use along with a dopamine antagonist. And it may not be the best thing for this child. Also, it would be important to look at why the melatonin is being used. I presume that that's taken at night for sleep. An alternative to that could be tryptophan, which is back on the market now following all of the concerns in the prior decade about the eosinophilia myalgia syndrome that developed in the 80s, I think. And there is some information that suggests that tryptophan may actually suppress appetite when given in pharmacologic doses, even though we often think of it in other ways. So that can also promote sleep for individuals, and that's something we could talk about further if you'd like.
Thank you. I have one additional question for anybody who might know. I believe that there are specialized services, including nutrition services, for children with Prader-Willi syndrome at UNM. Are those available would that be available to my patient?
I believe they will. They
Yes.
are.
Anything that's what they call Prader-Willi-like, and it sounds like this child would qualify for that.
And that's a great suggestion. How do we get that hooked up?
I will get that to you, Dr. Chilton. I'll give it to Dr. Colleran when she gives you your summary. Loretta Pacheco is the nutrition provider in that program, and she has 20-some years experience working with this population. And I'm not sure, used to be we had to go through Carol LaRocque to determine Prader-Willi-like, so I don't know if she's still in charge of that program. But in my past experience, it basically was a phone call to her with a case presentation with the situation, and they had some way of doing an assessment. So I don't know if that's still the process, but we'll find out for you.
Yeah, we'll help facilitate that.
Thank you.
Thank you. Really very interesting case. We'd love to hear back from you about if you were able to implement any of these changes and if they were at all effective.
Well, thank you. I think that if I have portrayed the mother as being other than intelligent and interested, I didn't need to. She is both intelligent and very interested, and she'll be very appreciative of all your advice. Thank you.
That did not come across at all, so no worries. Okay, well, I'm going to take the liberty of presenting a very limited case. And this was a case that was presented to me at the Adult Diabetes and Cardiac Care Clinic, Echo Clinic. So I have all the information I had then, which wasn't a lot. But I'm presenting this on behalf of Lee Dubois, who's the diabetes coordinator at the Pecos Valley Clinic. And he presented a 6-year-old female, Hispanic female, who has significant obesity and probably a dysmorphic syndrome. So, so their questions were, is there a syndrome that may be causing her problems, what further tests should be done, and how to deal with the excess food foraging. The child is 3 feet 9 inches tall, 100 pounds. I don't have the percentiles on those, but the BMI percentile is greater than 99%. Again, limited information, blood pressure wasn't done. Regarding family history, both parents are overweight, but not, quote, obese. And there are multiple siblings in the family, and their body habiti, is that a word? Are unknown. And there is a history of diabetes. Really no information about the child's past medical history. He does live with this multiple generation families. So the next thing that I have is physical exam. Both the diabetes coordinator and the social worker at this clinic separately said she doesn't look normal. So she has some features, facial features, etc., that they weren't able to really elaborate on, but they both sort of came to the conclusion independently that there seems to be something wrong. Severe acanthosis nigricans, quote, the worst case I've ever seen. So pretty diffuse all over. There's no truncal obesity, but diffuse adiposity. They did have an A1C because they have a point of care testing machine there, so it was 5.2. And that was it. The mother brought her in because she was very concerned, so her readiness to change is a 10. And so it's definitely seen as an issue by the parent. There also, I didn't mention this, but I thought I put it somewhere. Question of, so when she doesn't make eye contact, and she has this sort of gaze that, again, didn't appear normal. Did I put that somewhere?
It's under mental health
Oh,
assessment piece.
I know, it didn't belong there, but that's where.
No, it's fine. It goes
Where'd it go?
to the top of the page. Back page.
Under depression.
It's under the depression
Mental
screening.
health depression, abnormal affect, not engaged, no eye contact.
Thank you.
Yeah,
Aye.
eye.
So, so my first thought and their thought as well was that, does this child have some dysmorphic syndrome, just like the case that Dr. Chilton presented, and how do we best evaluate for that? And it seems to me that that's probably would be an appropriate referral, and I don't remember who the people are.
For
For
Is it
pediatric
genetic
genetics.
or is it?
It's pediatric genetics.
And it's not Carol Clarkuzio?
She
anymore?
is still
I'll
with
make
the,
those ones, but
yeah.
2726631.
6331.
2726631.
Okay.
Vivian will track somebody down.
Okay. Does anything come to mind? It could be Bardet beetle, but I don't know if that occurs in girls.
I was trying to decide on the growth, because it'd be kind of nice to know if her height percentile is low. Do you know those off the top of your head?
Of course, I have them all
Yeah.
memorized. Every growth chart ever
I'm just
created.
checking.
But we can
But
figure it
just-
out here.
Because a lot of the syndromes can
They're
have some
short
short
stature.
stature, not
Yeah.
absolutely. And then
And
I
that's just
figured-
like the Chilton patient as well.
And you would know this, but did she have stria or?
There was no
We don't
stria.
know.
And again, it's diffuse obesity, and so you'd be less likely to see that unless you have it really, you're stretching the skin of the abdomen.
I'm looking at the growth chart, so we can continue to talk.
Okay, so I just thought that was kind of an interesting case, which I knew nothing about.
What do you think about the acanthosis as an
Well, yeah.
endocrinologist?
I know, see? So that really bothers me, and when I think about things that cause severe acanthosis, well, it's just stepping back. Again, you would expect more central obesity if it's an insulin-resistant syndrome. There are very bizarre endocrine disorders, particularly a glucagonoma, which can present with severe acanthosis that also tends to migrate, but also presents with severe insulin resistance. And so we're not seeing that piece with the A1C of 5.2. And so one, is it acanthosis? Is it something else we need to be concerned about? And is there some other disorder that can cause that degree of acanthosis? And that
Other places for the acanthosis, wouldn't you expect, or?
Yeah, no, I mean, he, you know, if you say worst case scenario, it's sort of like, you're looking all over.
And this is a girl?
A girl,
Yeah.
yeah.
Does she have moon faces and a buffalo hump?
I can't even look at him. Don't
Well,
put
what
that
I'm-
on film.
I'm-
No.
I'm really wondering about, and I'm sorry that it's not fresher in my mind,
No,
but I'm really wondering about what's that really large molecule that includes ACTH and the melanocyte-stimulating
right.
hormone, pro-opioicortin or something?
Palm C.
Thank you.
You're welcome.
Could there be a hypersynthesis and secretion of
She's
that
not short.
huge molecule that's causing an increase in pigmentation, or would that be a more generalized pigmentation?
So what Dan is referring to is, does she have a problem at the level of the pituitary where she's, one, making too much of the precursor to ACTH, And attached to that precursor, which is called Comm Tc, is a melanocyte stimulating hormone. There's an what's the opio called? I can't remember. But anyway, so she could indeed have a pituitary problem, and she would be hyper secreting these things, and that would then lead to hyper secretion of cortisol, which would cause the moon phases and the buffalo hump. But again, it's usually centralized obesity, and so this diffuse picture kind of goes against that, but it's actually a great thought. If you have that, you tend to have you get hyperpigmentation. It can be global, but it can be patchy, and it tends to occur on buccal mucosa, the palmar creases of the hands, and the extensor surfaces. But you could probably confuse the two. So that's a great thought.
With acanthosis?
Yeah, I mean, you could.
So just to answer your question, she's at the 50th percentile.
Okay.
So she's not short.
But would it migrate? That's the thing.
No, and hers doesn't migrate.
It doesn't migrate.
But with this glucagonoma thing, which I've never seen,
It migrates.
it migrates. But you also, I think, get diffuse acanthosis. But again, both that and hypercortisolism, you would expect some degree of insulin resistance, which we may not be seeing yet. I mean, we're seeing it with the acanthosis, but not with the one blood test that we had.
Well, it does raise the question of whether you can get the hemoglobin A1C be normal while the person already has developed AN. Isn't that unusual? Isn't it usually thought that the AN develops before, or excuse me, after there is an elevated A1C?
No, it's actually before. And so it's a marker of insulin resistance. And remember, in early insulin resistance, the pancreas is pumping out way more insulin than a normal person to make the blood sugars normal. Mm-hmm. So initially you have high insulin but normal glucose, and one of the side effects of that is this hypertrophy and this acanthosis. Okay. And so then eventually the pancreas can no longer keep up. So insulin secretion goes down and sugars start to go up. So you could certainly see it, but I would just anticipate with that degree of severity that they're recalling, you would think there would be some already signs of hyperglycemia, but not necessarily. Okay, other questions or comments from the general audience? And before we get there, I don't know if you're still on, Dr. Chilton, but we did want to find out if the patient you presented was a Molina patient. Is he on?
I believe he's disconnected.
Okay. I'll send you that question in my response to your presentation, even though you're not on and listening to this anymore. Other comments or questions from the audience on these cases, the didactic or anything else related to pediatric obesity? Remember, if you do have a Molina patient, Molina is willing to reimburse you for presenting that patient at the tune of $150. They also have some resources, particularly if the patient does have type 2 diabetes. Unfortunately, I don't think they have anything for pre-diabetes or at risk for, but we can help you figure out how to get that reimbursement if you do present such a patient. And I believe if there's no further questions, we'll call it a day and see you in 2 weeks.
Is there anybody left on the line so we can do just a final roll call?
This is Pamela Doster, still in Socorro.
Thank you, Pamela.
You're a trooper.
That was good information, thank you.
Anyone else on the line? Okay, well, thank you, everyone. Have a good weekend.